I would like to call on Dr. Jude-Marie Sena to come forward and present our keynote speaker.
I think I will have nothing to say to present Dr. Williams. You already know Dr. Williams, I think, better than me now. And just to say, first, thank you for being there, and thank you to show us the path. I think without your work, maybe we will not be there. And I think this is the only thing I can say. And when I said before, when we talk about you in the milieu, we say the Pope, it is because of what you have done. And I think what you have done is not just for the Black communities, not just for the racialized communities, and every person, like each person, supposed to be proud of that, because what you have done is to have a better humanity. And when we have a better humanity, it is not about Black people, it is not about racialized people, it is about the human being. Please, ladies and gentlemen, welcome Dr. David R. Williams.
It's truly an honor and privilege to be here with you. And I've been inspired by all the leadership I've heard and all the vision and plans for this place. I want to begin by apologizing that my French is non-existent. I should be doing better. I grew up on the island of St. Lucia. Those of you who know the Caribbean, from my home in St. Lucia, every single day I saw Martinique, if it wasn't cloudy, a French territory very close. Never been to Martinique, to travel around the world, but haven't been to Martinique. St. Lucia has, of all Caribbean islands, have a stronger French-English fight. There were 14 times in the wars of the 17th and 18th century it changed hands between the British and the French until the Treaty of 1815. It was British since then, but all place names in St. Lucia are French, reflecting the strong French influence. But I took 2 years of French high school, but that's decades ago. I know nothing today. So you'll have to tolerate with me as I speak in English and share with you some of the research on the challenges that we face in terms of the health of Black populations, but also want to talk about what we can do about it. I want to begin by setting the stage. A lot of the research I will share was from the US, not all, but there's a lot we can learn. And things are not necessarily identical, but there's a lot we can learn. So I want to begin by talking about what I call America's mental health crisis. The best national data we have suggests that almost half, 46% of US adults have a DSM 3 or 4 defined psychiatric disorder. 28%, that's almost half. 28% experience 2 or more disorders. Half of US adults experience a serious mental illness by the age of 55. 26% of US adults currently have a disorder, with 60% of these rated as severe or moderately severe. By age 18, 1 in 5, 20% of youth have a case of clinical depression. So there is a huge challenge of mental health in the United States. I want to share with you data on the distribution of psychiatric disorders by race and ethnicity in the US. This reflects the coordination of multiple studies, the National Comorbidity Study run by Dr. Ron Kessler, the National Study of American Life that James Jackson ran. I was one of the MPIs on that study that looked for the first time not only at the largest national study of mental disorders in the Black population, but the first study to include a national sample of Caribbean immigrants and Blacks of Caribbean ancestry. I will share with you findings from that. And that was coordinated by Maggie Allegria and David Takeuchi doing national studies of Asian Americans and Latinos. So this is the data. Lifetime prevalence of psychiatric disorders. And you could see whites actually slightly highest. If we exclude the Puerto Ricans, that's Puerto Ricans in the US. You see blacks lower, with African Americans having slightly higher rates than blacks from the Caribbean. And you could see some variation across various Hispanic groups. It's no problem. You can see variation for various groups of Hispanics with Puerto Ricans, and that's not Puerto Ricans in Puerto Rico, that's Puerto Ricans living in the continental US, having the highest rate, slightly higher than any other group in the United States, and you can see some variation among the Asian populations as well. So this is mental disorders by race and ethnicity in the United States. If we stop there, we miss an important point. So I want to share with you taking a deeper look at mental disorders. So blacks have lower rates of major depression than whites in the United States. That's what national data reveal. That's true for African Americans, it's true for blacks of Caribbean ancestry. But depressed blacks are more likely than depressed whites to be chronically or persistently depressed. They are also more likely to have higher levels of impairment, lower levels of functioning in their daily lives. They also have more severe symptoms, and they are less likely to receive treatment. So if we just stopped at the prevalence data, we would say maybe not a big problem, but when we dig a little deeper, we can see levels of severity that are missed by just looking at the prevalence data. And here from these studies, what we also found among persons who met criteria for major depression in the last 12 months, 57% of American adults had received treatment. 45% of African Americans had received treatment, but only 25% of Caribbean blacks in the United States had received treatment. So looking at subgroups and looking at variation of subgroups becomes very important in getting a handle on the challenges we face. We have also looked in these data on migration and mental health. And here is what we find. The lifetime prevalence of psychiatric disorder among blacks, Latinos, Hispanics, I use the terms interchangeably, and Asians. And for every group, you can see the prevalence is higher for the US born. The foreign born have lower rates of lifetime prevalence, but it's also true for specific disorders. However, if we drill down a little bit more, as we were able to do, by not just looking at the US born and the foreign born, but we are looking here at a lifetime prevalence of psychiatric disorders by generational status in the United States among immigrants. So you could see for first-generation immigrants, those are immigrants from the Caribbean, their lifetime prevalence is 19%. For the children of immigrants from the Caribbean, it's 35%. For the grandchildren of immigrants from the Caribbean, it's 54%. So with increasing generational status, you see the same for Latinos. First generation, second generation, third generation, mental health is worsening. We honestly don't have a clear sense of what's driving that, but it is a disturbing pattern, and it tells us it's not enough to just look superficially at differences, but looking at subgroup differences can tell us a lot more of populations we need to target and work with in terms of addressing their mental health challenges. And I want to share with you also some disturbing data we unearthed about black Caribbean men in the United States. In virtually every country of the world, I'm part of the World Mental Health Initiative run by Dr. Ron Kessler, who was at the University of Michigan, one of my mentors, but is now at Harvard. Also, I directed a national study in South Africa, the first national study of mental disorders in sub-Saharan Africa. I led it in South Africa. There was another study in Nigeria that was a regional study by Oyeyere. But I'm saying in virtually every country of the world, women have higher rates of depression than men. But black Caribbean men in the US have a lifetime rate of depression similar to that of Caribbean women. Black Caribbean men have a current rate that's in the past year that was higher than that of Caribbean women. So I'm saying that's an outlier in terms of a pattern we generally find. It gets even more interesting. Black Caribbean men have a lifetime rate of mood disorders that is 1.8 times higher than that of African American men. Black Caribbean men have a current rate of mood disorders that is 2.2 times higher than that of African American men. Another study using the same data by Dr. Sean Joe showed that suicide attempts were higher for Black Caribbean men than for any other Black group. So there are some serious mental health challenges that we need to understand. But the point is, if we didn't drill down into the subgroups, we wouldn't find that. And this is so important to look not just at the overall population data, but look at subgroups and to identify what the challenges might be. We do not now know what are the drivers of this. I have some hypotheses. One of the hypotheses is that migration to the United States poses greater socioeconomic challenges on average for many Black Caribbean men. If you know US immigration law and the flow of Caribbean immigrants into the United States, one of the easiest way for a Caribbean family to enter the US is for a female to come as a nanny and works for 5 to 7 years as a nanny before she can get a green card, permanent residency status. At that time, she can sponsor her husband and any unmarried children. And so there are employment niches that Caribbean women fit in the United States. Another pathway for those who've had education is to come as a nurse. There's a nursing shortage in the United States. And again, mainly women, and then they can bring the family. So there's evidence to suggest that Caribbean women have easier times finding employment niches in the US, and then the men come subsequently in a foreign land where the woman is now, coming from a patriarchal society, the breadwinner. And the expectation that they are now in the US, and people in the Caribbean region think that there's money flowing on the streets in the US, have high expectations that these men would send back money back home, and they have little resources to provide to send back, and they are struggling with this new status. I think that's a hypothesis, but I have no data that that is in fact the case. The point is, let us drill down though on what's the context of the lives of racial ethnic minority implications that might have implications for their mental health. I was trained at the University of Michigan as a sociologist, and I learned that socioeconomic status, whether measured by income, education, occupational status, is a central determinant of the distribution of virtually any desirable resource in society you look at, including physical health and mental health. And race and ethnicity is strongly related to socioeconomic status. This is national data for the United States, median household income by race and ethnicity in 2018. I'm going to show you the same data in a way you can't miss the point. For every dollar of household income white households receive, Asian households in the United States receive $1.23. Several caveats to keep in mind. Almost 2/3 of Asians in the US are immigrants. They've come to the US with high levels of education, or they have come to the US for education. So that's one point. Another point to keep in mind as you look at the Asian situation, Asian households are more likely to be what we call multi-generational households. So they have more persons contributing to household income than any other racial groups. So those are caveats to keep in mind. And the third caveat that applies to all populations, there is what we say in epidemiology, heterogeneity in all of these categories. There's a lot of variation. So there's subgroups of Asians, the Hmong, the Laotian, Cambodian, they're Asian, they have lower levels of income than African Americans or Native Americans. So those are contextual factors to keep in mind. But let's look at the historically disadvantaged groups. For every dollar of household income white households receive in 2018, Latino households or Hispanic households 73 cents, Black or Native American households 59 cents. Do you know what is stunning about that 59 cents figure for Blacks in 2018? That is identical to the Black-white gap in income 40 years earlier, in 1978. 1978 was the peak year of the narrowing of the black-white gap in income as a result of the war on poverty and the civil rights initiatives of the 60s and 70s. It got to 59 cents. It was worse than that. And in 2018, it's still 59 cents. Most Americans think there's a movement in America right now. We have to dismantle affirmative action, diversity initiatives because they're discriminating against whites. Where is the progress that has been made? And it's a penny up and down since then. I looked the last time it was 60 cents for the most recent data. So we have made much less progress than most people think. And large racial gaps in income dramatically understate the racial gap in economic status. Because income tells us about the flow of resources into the household. It tells us nothing about the economic reserves to cushion shortfalls of income. We get that from data on wealth that captures your home equity and your savings and your investments and so forth. And the latest data, 2022, for every dollar of wealth that whites have, blacks have 16 cents, Latinos 22 cents, other races 47 cents. Other races a combination, largest group in other races is Asians, but it's a combination of all the other groups. So the point is, when you are low in income and low in wealth, we could all be in the same storm, but we're not in the same boat. And some boats are just not able to weather the storm. And we saw that during the pandemic. All of the disadvantaged groups have markedly higher elevated rates of mortality during COVID-19 pandemic than others. When my career started, most researchers thought that racial ethnic differences in health were simply a function of racial ethnic differences in income and education. And if you compared blacks and whites, for example, at the same levels of income and education, race would no longer matter. We now know life is more complicated than that. And I want to share with you national data for the United States. I'm going to looking at life expectancy at age 25. At age 25, how long will the average person live? And at age 25, the average white person will live 5 years longer than the average black person. So there's a 5-year gap. That's the race gap. But if we look by income and education, the gap within each race is even larger. I'm going to show you only the education data in the interest of time. So whites with a college degree or more education in the US live 6.4 years longer than whites who have not finished high school. That's bigger than the black-white gap. And if you look within blacks with a college degree live 5.3 years longer than blacks who have not finished high school. Again, that's bigger than the black-white gap. So should we abandon collecting data by race and just look at socioeconomic status? And I would say not so fast. Why? Because race matters at every level of socioeconomic status. So white high school dropouts live 3.1 years longer than black high school dropouts, and the racial gap increases as income and education, I'm only showing you the education data, increases. This is national data for the United States. The best off blacks, those with a college degree or more education, have lower life expectancy than whites with a college degree, lower life expectancy than whites with some college education, lower life expectancy than whites who've graduated from high school. So what do these data tell us? They tell us there's something about income and education that matters for your health regardless of your race. But there's something else about race that matters, even after you've taken income and education into account. So why does race still matter? What is the science clearly telling us? That racism and racial discrimination are alive and well and has dramatic negative effects on physical and mental health. And racism is a critical missing piece of the puzzle to understand the patterning of racial inequities in health. So let me talk briefly about the house that racism built. What do I mean when I use the term racism? I'm talking about an organized system, a system that categorizes and devalues some groups, disempowers some, empowers others, differentially allocates resources. So it's primarily a system at a societal level. But yes, it's built on an ideology of inferiority. You can classify human groups, and some are superior and some inferior. And yes, it leads to negative attitudes and beliefs, prejudice and stereotypes. And yes, it leads to discrimination by individuals and institutions. But racism is primarily a societal system. Stokely Carmichael and Charles Hamilton wrote a book back in 1967 about black power, and they coined the term institutional racism. And they used that term to describe racism that is built into laws and practices in the culture of society and its institutions. In the last 10 years, some people new to the field, not knowing the history, are saying institutional racism is only what happens within institutions. That's not how the term has historically been used, as Joe Fagan points out. James Jones was an African-American social psychologist, wrote a book in '72 about racism, and also used this broader term. And so I use structural or systemic racism and institutional racism interchangeably in the spirit of how it has been originally been used. And back in 2001, I published a paper with one of my former students where we argued that in the United States context, racial residential segregation was a fundamental cause of racial disparities in health. What did we mean by that? And for the Canadians, I need to be clear on what I mean by racial residential segregation. In the United States, historically, where you could live depended on your race. And this was enforced by the banks, by laws, and by vigilant neighborhood organizations. Although it's not legal anymore, the structure put in place is largely intact. John Sell was a historian at Duke University. He wrote a book about the origins of segregation in the US South and South Africa. He showed that the framers of apartheid in South Africa in the late 19th and early 20th century got the idea of apartheid from looking at how well residential segregation was working in the US. And he also argued that residential segregation was one of the single most successful domestic policies of the 20th century in the US, because it's beneath the radar screen. No one politician in the current election is talking about it, but it's a driver of inequities. And somebody says, what does segregation have to do with anything? We want to talk about mental health. Well, think of segregation like a burglar at midnight that slips into a community. And once it shows up, valuables disappear, like quality schools and safe playgrounds and access to good employment opportunities and a healthy living environment and safe housing and high-quality transportation and even access to high-quality medical care. Research in the United States reveals that all of these desirable resources vary by your zip code. I think you use the term postal code, vary by where you live, vary by your neighborhood. So segregation determines access to opportunities. You want empirical evidence? Let me share with you some evidence. This is William Julius Wilson and Robert Sampson, two of America's most eminent sociologists, studied 171 largest cities in the United States. And because of residential segregation, there's not even one city where whites live in equal conditions to those of blacks. And they concluded the worst urban context in which whites reside is considerably better than the average context of black communities. If you're paying attention, that's a 1995 study, so you said, well, David, have things gotten better since then? I want to share with you the work of Professor Dolores Acevedo Garcia. She was in my department. She's now at Brandeis. She's created a neighborhood opportunity index, ranking every county in America and every census tract in America on 29 different indicators of access to opportunity for kids, like the high school graduation rate and the quality of the schools and median household income and home ownership rate and employment, and the quality of the environment, air, water, soil, and resources for health like access to green space and healthy food outlets and so on. It's called the Child Opportunity Index, but it applies to everyone who lives in the neighborhood. And what did Professor Dolores Acevedo Garcia found? If she looks at the 100 largest metropolitan areas in the United States, and she asks which children in America live in the very low and low opportunity neighborhoods, 2/3 of all black children live in the two worst, lowest quintiles of opportunity. 58% of Latino kids, 53% of Native American kids, compared to 1 in 5 white and Asian kids. On the other hand, who lives in the high opportunity neighborhoods? Almost 2/3 of all white children and all Asian children, compared to 1 in 5 black and Latino kids. So place is a powerful driver of access to opportunity. In fact, research indicates that the reason why there are racial ethnic differences in income and education and occupational status in the first place is because of segregation. Let me share with you two studies from Harvard economists. David Cutler, he was the dean of social science when I joined Harvard 18 years ago, one of the country's leading economists, using national data for the United States, looking at black and white young people making it in the labor force, using fancy econometric models I cannot even fully describe, he's able to show statistically, if you could eliminate residential segregation in America, you would completely erase black-white differences in income, in education, and in unemployment, and reduce black-white differences in single motherhood by 2/3. All of those striking differences are linked to opportunity at a neighborhood level. One more study, one more Harvard economist, Rash Chetty. Rash Chetty has done an amazing intergenerational analysis. He's gotten access, not a sample, all US census data from 1989 to 2015. And he's asked a simple intergenerational question. He said, let me compare black and white children who begin life with their parents at the same level of income. How are the children doing in the next generation? So he's controlled on income. And you know what he's found? In 99% of census tracts are geographic areas in America, black boys have lower earnings than white boys, even when they started out life in households with the same level of income as the white boys. Why? They're not working hard enough? They're lazy? No. They live in neighborhoods that differ in access to opportunity. Black boys do as well as white boys if they live in neighborhoods with good resources, but that's true for very few black children in the United States. So what does these data tell us? The racial inequities in socioeconomic status that matter for life and health do not reflect a broken system. No, they reflect a carefully crafted system functioning as planned, successfully implementing social policies, many of which are rooted in racism. The inequities we see are not random events, they're not accidents, they're not acts of God. They reflect the ways in which structures put in place has produced a truly rigged system. And segregation is the central driver of the elevated rates of violent crime and homicide in the United States. I'm going back to the work of Robert Sampson, one of the country's leading criminologists, the chair of the Department of Sociology at Harvard. He has studied this relationship, and he shows that residential segregation leads to lack of access to jobs, high male employment and underemployment. High male unemployment and lack of access to jobs leads to high rates of out-of-wedlock births, female-headed households, and the concentration of urban poverty. In female-headed households, there are lower levels of supervision of adolescent males, and that leads to increased adolescent risk behavior. So these are mechanisms that he has documented statistically that drives the elevated rates of violence and crime in black communities. Importantly, he shows that the association between male unemployment, poverty, and family structure with adolescent risk behavior, violence, and homicide is identical in sign and magnitude for blacks and whites. Why is it more common for blacks than whites? Because blacks are more exposed to the conditions that give rise to those conditions. He indicates racial differences in adolescent risk behavior are driven by racial inequities at a neighborhood level in the availability of jobs, concentrated poverty, opportunities for marriage, and family structure. So I'll show you the debate we are having in the United States. Many people realize that there are problems with family structure, that leads to high rates of violence, crime. The Heritage Foundation is an influential think tank in the United States. So if those of you follow American politics closely, the Project 2025 has come from them. It's a blueprint that Trump is distancing himself for verbally, but his advisors are the drafters of it with the Heritage Foundation. But anyway, they have come up with a solution to the family structure problem in the United States. They're saying the reason why there are a lot of female-headed households, there aren't enough marriage rates, is the poor people aspire to the marriage, but they lack the norms and the understanding and the skills to achieve it. And therefore, they recommend that the federal government needs to provide information to poor people so that poor people know what they need to do about getting married. That information is the key. I want to give you an alternative science-informed policy implication. The question is, wouldn't increasing economic opportunity for males increase marriage rates and reduce racial disparities in marriage? That is a question that sociologist Jay Teachman asked, and I'm going to show you findings from 3 studies that he did. He said, let's look at black men in the military. This is true in the US, that in the military it's documented there is less discrimination in the military than in the civilian societies. Not that there's no discrimination, but there's less discrimination in the military. And that, they think, is the command and control structure facilitates that. And a young male who enters the military can have a long career in the military with good, reasonable income, and also good benefits, including family housing, daycare centers, and so on. So what Jay Teachman did, he said, let's look to see what's the impact of enlistment in the military on marriage rates. And he's documented that active duty military service, in one study, promotes marriage over cohabitation. A second study shows it increases the likelihood of first marriage, and the third study shows it leads to greater stability of marriage. All of these effects were true for blacks and whites, but the effects were greater for blacks than for whites. So I don't think military enlistment is the key, but what this illustrates is that providing good economic opportunity for males gets at the heart of the problem and solves some of the challenges that we deal with. Very different than just providing information to poor people about the benefits of marriage. So we've talked about upstream racism, and it has downstream consequences, and one of those is individual discrimination. The stress of interpersonal discrimination is a source of toxic stress that adversely impacts mental health. This is a hypothesis offered by Martin Luther King. He was not a scientist, but if he was correct, discrimination is a hellhound that gnaws at Negroes in every waking moment of their lives, declaring that the lie of their inferiority is accepted as a truth in the society dominating them. This is a paper I published years ago when we first introduced measures of discrimination to the world. And the context of developing those measures was I was at a conference in the early 1990s, and I talked about one of the priorities for future research on understanding racial inequities was for us to develop measures to capture racism. And a gentleman raised his hand and he said, what Dr. Williams says to do is a good thing, but it's impossible. We will never be able to measure racism. And I remember saying to him, we measure self-esteem. If we measure, and I don't know why I picked self-esteem, but that's what I said. I said, we measure self-esteem. If we measure self-esteem, why you think we can't measure racism? We just haven't put our minds to it. And I put my mind to it with the support, I'm going to talk about him later, Dr. James Jackson, a real giant in the field, and he and I came up with a bunch of measures. That's the paper that published them. There are multiple measures, but this one has had the most traction and has produced the most striking effects. Everyday discrimination. It's not all of discrimination. It's not the big things. It's the little indignities. Being treated with less courtesy and less respect. Receiving poorer service than others. People acting as if they think you are not smart, or they're afraid of you, or they think you are dishonest, or they're better than you are. Just the little indignities. And the findings with them have been quite striking. This is a summary of mental health outcomes linked to persons scoring high on everyday discrimination. Higher rates of DSM-defined mental disorders, of major depression, of generalized anxiety disorder, of substance abuse disorder, increased emotional distress, decreases in psychological well-being, lower life satisfaction, lower self-esteem, changes in personality, poorer sleep, and lower adherence to following through on recommendations from their clinician. All linked to higher levels of everyday discrimination. And it's not just mental health, it's also physical health. I'm showcasing the work of Tenny Lewis. She was at Yale, now at Emory University. Every line I'm going to put up now reflects a different published peer-reviewed study. Higher levels of everyday discrimination predicts higher levels of coronary artery calcification, higher levels of inflammation, higher levels of blood pressure. Pregnant women who report everyday discrimination give birth to lower birth weight infants. A study of the elderly followed over time. Everyday discrimination is the predictor of more rapid declines in cognitive function. It's linked to poorer sleep. One study of adults followed over time, scoring high on everyday discrimination, those little indignities, is an independent predictor of premature death. A study of black and white women, dose-response relationship between everyday discrimination and visceral fat, the deep internal fat, unrelated to subcutaneous fat, but a deep internal fat, abdominal fat that matters. It's a dose-response relationship. Shorter telomere length, arterial stiffness, incident cardiovascular events, just to give you an example of how powerful discrimination is and how pathogenic it is for individuals who experience it. I want to share with you a study. This is Arjuman Siddiqui from the University of Toronto, national data in Canada of 16,000 Canadian adults. Blacks and Aboriginals had the highest levels of experiencing any discrimination compared to Asians and whites. Some measures, such as being feared by others or receiving poorer service than others, were reported by blacks and Aboriginals 3 or more times as much as Asians and whites. Discrimination was associated with higher odds of having a chronic condition like arthritis, back problems, diabetes, heart disease, and cancer, and higher obesity, higher binge drinking, poor self-rated health. So it matters across context. By the way, there's studies of everyday discrimination in literally more than 60 countries around the world. We find the pattern matters. And the everyday discrimination doesn't capture all of discrimination. That's a mistake I think some people are making. Oh, they've got the everyday discrimination scale, they've captured racism. And it's like you've captured one small piece of it, not even all of the interpersonal discrimination. There's evidence of work discrimination mattering for health. This is from a study we did. These are some of the indicators of work discrimination. There's evidence of major experiences of discrimination, being unfairly fired, unfairly denied a promotion, stopped physically threatened or abused by the police. All of these are experiences of discrimination. And there's also evidence of the perceived threat of discrimination. Research in the United States finds that even while sleeping, black people maintain a higher level of vigilance. Seriously, and that higher level of vigilance while we are asleep is linked to increased risk of mortality and cardiovascular disease. And research finds that people who score high on discrimination in their life during the day don't sleep as well because you have to sleep with one eye open. Your environment is stressful and dangerous. And based on that, one of the things I developed was called the heightened vigilance scale. That asked individuals, after we talked about discrimination, we said, in dealing with these events, how often do you think in advance of the kinds of problems you're likely to experience? How often you try to prepare for possible insults before leaving home? How often you feel you always have to be careful about your appearance to get good service? Does this sound familiar? How often you carefully watch what you say and how you say it and carefully observe what happens around you and try to avoid certain situations and places? And what the research finds is that people who score high on vigilance affects health independent of actual exposure to discrimination. Blacks have higher levels of vigilance. It predicts elevated depression and contributes to the black-white disparity in depression. It predicts elevated risk of sleep difficulties As vigilance increases, the racial ethnic gap in hypertension widens. Vigilance remains predictive of hypertension when adjusted for actual exposure to discrimination. So the threat of discrimination out there is also a source that adversely impacts mental health. And importantly, beyond exposure to interpersonal discrimination, even if you measure it comprehensively, the inequities that I talk about at neighborhood level and access to socioeconomic status matters for a broad range of stresses. And that's why I said I get troubled when people feel they use one little scale and tell me they've captured racism. Because racism leads to a broad range of other stresses. This is a study we did years ago at City of Chicago, where we found that blacks and US-born Latinos compared to whites had higher levels of every type of stressful experience we captured. Higher levels of major life events, like the death of a loved one or unemployment. Higher levels of financial stress, higher levels of work stress, higher levels of stress in relationships, higher levels of neighborhood stress, plus the stress of discrimination. And what we found was a dose-response relationship between every additional domain of stress individuals were high on both their physical health and their mental health. So that if we want to characterize the challenges of populations and assess the health impact, we need to capture stress comprehensively because all of life takes a toll on what people are experiencing. On top of that, there is now a growing body of research that suggests there are hidden ways in which stressors linked to race adversely affect health, especially mental health. Here is a study, the first study of online discrimination led by Brendisha Tynes. She was a postdoctoral fellow with me at the time she published this. This is 2008, where we looked at middle and high school students in the United States, and we asked them about experiencing discrimination in online contexts. And what we found was that online discrimination was linked to both depression and anxiety symptoms independent of discrimination offline. So there was what's happening in the online context mattered. Here is a more recent study. She's now a professor at the University of Southern California. You know, I get so proud of my students and fellows I've worked with that go on to greatness. She's gone on to greatness. She's the leading researcher looking at what's happening online to kids. And here's a 2019 study she did of Latinx and black adolescents 11 to 19 years old. She assessed the frequency in the last year in which they'd seen someone of their own racial group being beaten by the police, arrested or detained, or being shot by the police. And exposure to traumas in the past year, just what they had seen online, the news and other online contexts, is linked to higher PTSD symptoms and depressive symptoms. So what we are experiencing takes a toll. It's not only what's personally targeted at me. Another study found 70% of black women said they were very concerned that their children might be harmed by the police. What does that do to their anxiety levels? And a study of 3,000 mothers in 20 cities called the Fragile Family Study found that almost 1 in 5 urban youth are stopped by the police by age 15. And mothers of youth who were stopped by the police were twice as likely to report depression and anxiety-related symptoms. And here's another study. This one was done by one of my former students. I worked with him on this paper. He's now at Boston University, faculty. We got a data set that had every police shooting in the United States. And we linked it to another data set from the Centers for Disease Control of the mental health of the population in each state. And what we were able to document is that every police shooting of an unarmed black person led to worse mental health, not for the family and friends, but for the entire black population in that state for 3 months. For 3 months, their mental health symptoms are elevated. It was a specific effect. I did not say it was every police shooting because it wasn't. It was every police shooting of an unarmed black person. If the black person was shot by the police and they were armed, no effect on mental health. But if the person was unarmed, it meant you didn't have to be doing anything wrong. And it could happen to you, your siblings, your parents, anybody. And so what we are talking about is, we're talking about mental health, is what's happening within the larger community has ripple effects on health. The adverse effects of discrimination begin early in life. And I'm going to share with you what I call the most disturbing study that I have read recently. The toll that racism is inflicting today on young black children in America. This is a study of suicide in elementary school children in the United States. The researchers used national data looking at from 1993 to 2012. And what they found was the suicide rate was stable overall in the United States. But when they broke it down by race, the suicide rate was stable only for Latino children and Asian children, had markedly declined for white children, had doubled for black children. This study, the researchers correctly noted, this was a 2015 study, that this was the first study to find higher rates of suicide among blacks and whites. Because for 100 years, if you look at the 15 leading causes of death in the United States, blacks have lower rates of suicide than whites. For 100 years. And the first study to find it is among children 5 to 11. Why it's hard for me to process this, I try to think back to when I was growing up in St. Lucia in elementary school. Did I know what suicide was? And to think that children 5 to 11 are committing suicide at a high rate. And it raises the question, what does it feel like to be a black child growing up in America today? The researchers were so struck by the pattern the same, they did a follow-up study, and they saw that the suicide rate up through 2015, it didn't stop at 2012, for those younger than 13 was twice as high. For black boys and girls have suicide rates twice as high as white boys and girls. Why? The ABCD study is a large study of 11,000 children, large sample across the United States, average age 11. In this study, these kids are alive, so they're not looking at suicide, but they're looking at suicidal ideation, how frequently you think about committing suicide. And they found that black children, 11 years old, had the highest rate of all racial groups of thinking about suicide. They also had the highest rates of reported discrimination. And when, in their statistical model, they looked at the relationship between race and suicidal ideation and added discrimination to the model, the effect of race was no longer significant. In other words, the racial differences in suicidal ideation are completely accounted for by the elevated rates of exposure to discrimination. So the discrimination that young people are feeling matter profoundly. I want to talk to solutions in a minute, but let me talk about one other thing when we talk about youth. I can't talk about this and not talk about social media. More social media has been linked to worse health for young people. Heavy use of smartphones and social media negatively affects, this is a Canadian Medical Association journal article, negatively affects academic performance, sense of self, and mental health. As hours per day increase on smartphones, happiness, life satisfaction, and self-esteem fall. Increased screen time linked to less sleep and thoughts of suicide in school-age kids and teenagers. There's been a global increase in suicide among 15 and 16-year-olds. This is a study where they've been looking every year in 37 countries at loneliness. And what they found in 36 of the 37 countries, South Korea is the only exception, loneliness has increased between 2000 and 2018. And nearly twice as many adolescents lonely in 2018 compared to 2000. And 2012 was the start of the marked increase in loneliness. What else happened in 2012? It was a year with steep increases in smartphone and internet use globally. So there is a relationship between the two. And the increase in loneliness is larger for girls than boys. What I'm saying is we now have evidence that the psychological well-being of teens around the world began to decline with the rise of smartphone and internet use. Now, I'm not saying that kids shouldn't use smartphones or internet, but we need to think of how they use it and put some controls in place because it matters. The Surgeon General of the United States has been talking about this issue, and he said just how we have a warning about tobacco, we need a warning on social media. Okay, I've talked about structural upstream racism. I've talked about individual discrimination. Before I talk about solutions, I want to touch briefly on racism embedded in the culture. The negative stereotypes trigger racial discrimination and reduce access to resources. I'm going to talk about only one resource: medical care. Implicit bias in medical care. I want to show you the kind of evidence we have. This was a 1999 study. Dr. Kevin Schulman went to a medical conference and had 720 internal medicine physicians look at a video. These were the actors in the videos that they each saw one video. All the persons said they were the same age, same occupation, lived in the same neighborhood, described their symptoms in identical words, were even trained to have the same facial expression as they described the symptoms. The only thing that was different was some were black and some were white. Some were male and some were female. And given the symptoms described, the appropriate next step would be catheterization, cardiac catheterization. But women and blacks were less likely to be referred for cardiac catheterization than men and whites. And remember, the symptoms were identical. The Congressional Black Caucus in the United States pushed the United States Congress to ask the National Academy of Medicine, the highest medical authority in the United States, to conduct a study to answer the question, did what happened at a medical conference with fake patients actually happen when people go into healthcare contexts in the United States? The result was this 2003 book called Unequal Treatment that documented across virtually every therapeutic intervention, blacks and other minorities received poorer quality care and less intensive care than whites. I served as a member of that committee. The findings were overwhelming. When Jack Geiger, who I talked about, he did the background research for the committee. When he presented 180 studies he found addressing the question, and 80% of them showed there were racial differences in the quality of care, not access to care, in the quality of care that individuals receive. This is a national press conference as the Washington Post talking about the findings of the commission. I just want to make the point, that's true in mental health care as well. Here's a book, one of my fellows, Morgan Medlock, and we edited this book on racism and psychiatry some years ago. And just to give you one study that we talk about in the book, research reveals compared to whites, physicians tend to spend less time in evaluating black patients. They markedly over-medicate black patients. They spend less time. There's a tendency to over-medicate black patients was lower when clinicians' efforts to engage patients in treatment, eliciting information for them, including the patient in planning, cooperating with them, responding with empathy. When those things were present, that pattern was not as strong. But I'm just saying there is evidence within the mental health treatment that there are differences in the quality of care. Now, I talked about this report was 2003. Last year was 2023. There were many conferences. 20 years later, have things gotten better? I spoke at 2 of them. What has changed in the last 20 years is we have more evidence that a problem persists. That's all that has changed. And I'll just give you one study to give you a sense. This is the 2023 paper of 318,000 elderly patients with Medicare, so they all have the same insurance. They're all dying with cancer in the last weeks of life. The question is, do they get opioid medication for their pain? They're dying of cancer. Black and Hispanic patients with advanced cancer are less likely than white patients to get opioid medications for pain. And when black and Hispanic patients get opioid medication, they get a lower dose. And then black patients, they're dying of cancer, they're more likely to undergo urine drug testing to see if they're abusing opioids. And black men experience the greatest inequality in not getting opioids and having to undergo urine drug tests. So it's just one study, but there are hundreds of studies now that document the persistence of this problem of the quality of care. So what can we do? There's no vaccine for mental health problems, but we need to encourage individuals to seek professional help. And adults receiving therapy, I showed this data before, in the United States, we have a problem among US adults with major depression. Half of whites, 45% of African Americans, Caribbean blacks, so subgroups, immigrant subgroups, we may need to pay special attention to, particularly marked. And one of the things that people are aware of is that a factor driving, I do not believe, I want to be clear, that healthcare providers wake up in the United States or Canada and other countries and say, how am I going to get my minority patients today? I don't think, it's not a deliberate, it's not intentional. And we think it's driven by implicit bias. I want to share with you, there is a study that shows we can eliminate implicit bias. This is a randomized, double-blind, parallel group placebo control. A single oral dose of a beta blocker eliminated implicit bias in providers for the next 3 hours. But can we medicate the healthcare workforce for the rest of their life? No, but I do think it's an important study. It's an important study because there are people on the political right, I don't know if this is happening in Canada and in the US, saying implicit bias is fake news. People have just made this up, it's not real. Listen, if we can intervene on it with a pharmacologic agent, this is something real occurring in the brain, okay? So I think that's where it's important. The good news is there are a number of strategies that have been shown psychologically that have worked in psychological studies to reduce implicit bias, like individuation. We tend, when we meet someone, to figure out what social category they belong to and put them in that category. This is our shorthand way of making sense of our environment. Individuation says, when I meet someone, I focus less on their individual, the social group to which they belong, and more try to understand that person as an individual. And don't assume because she's a woman or because they're that age, then these are the expectations I would have. But so there are a number of strategies. I'd like to talk about the Devine solution. Professor Patricia Devine at the University of Wisconsin-Madison has developed a program that is the single published, most successful program to reduce implicit bias. It helps to increase people's awareness, their concerns, implement multiple strategies. The implicit bias is reduced in the program, and 3 months later, it's still reduced. The typical things that are done, the 2-hour workshops and the 1-day seminars, raise awareness levels, but they don't change deeply ingrained behavior. What's different about what she does? It's a 12-week program, not a 1-day or 1 hour or a 1 hour online implicit bias training seminar you go to. 12 weeks with homework exercises to complete. And people who follow this program, it works to reduce implicit bias. So it tells us it can be done, but not in the way we typically approach it. What else can we do? Here's a paper I wrote with Lisa Cooper about reducing inequities in health. Strategy number 1, we need to ensure access to care for all. I'm not going to elaborate on that. We need to improve the quality of care. We need to diversify the workforce to meet the needs of all patients. And we need to provide care that addresses the social context. I want to give you one example of the latter. Diversifying the workforce to meet the needs of all patients. This is a study, randomized controlled trial, done in Northern California. Took 1,300 black men, sent them to a Saturday morning clinic. When they got to the clinic, they were randomized to see a black doctor. They were all black men, or a doctor of a different race. What they found was black men who saw a black doctor, more likely to talk about other health problems, more likely to do the screening for diabetes, more likely to get the flu vaccine, more likely to do the screening for cholesterol, greater engagement in the healthcare system, with the healthcare system, when there was racial concordance. Here is another study, just published again, 2023, that looked at every county in the United States. If there is at least one primary care provider, black provider, the mental health of the entire black population in the county is better the more black providers there are in the county. Looking at every county in the United States. Not every county has black providers, but the more there were, just having one made a difference, and if there was more, it made a difference. And this is the problem we face in the United States. A huge shortage of URM, underrepresented minorities in the health professions. You can see 5% of doctors in the United States are black, 5.8%, almost 6% Latino. You can see it's true for dentists, for nurses, for pharmacists. In 2014, there were 27 fewer African American men in the first year of medical school than in 1978. In the mid-1960s, 2.9% of all practicing physicians in the US were black. Today, 5% are black. But the Supreme Court ruled that you can't consider race because whites feel they are now being disadvantaged. And the question I want you to have, this is an important take-home point. Did affirmative action, these diversity programs that increased number, did they work for anybody? They haven't done much. It's better. 5% is better than 2.9% in 60 years. But do you know where there was great success with affirmative action? Affirmative action in the United States was for minorities and women. It has been remarkably successful for women. Look at the 1965, 6.9 of medical students in the United States were female. And by 2010, it was 48%. Today, it's 50% every year, between 49 and 51% every year. Most of these women have been white. The biggest beneficiaries of affirmative action policy in America have been white households. The greatest opposition to affirmative action policies in America are white households. It does not make sense to me, but that is in fact the reality. We need to think of what we do to increase diversity within the health professions. And this is the key. It is not enough to get to the starting line. Everyone must get the preparation to be able to compete in the race. So if you haven't changed the preparation and the quality of the elementary and high schools, just opening the door for black students to apply when they're not being prepared to be successful isn't going to work. It's what this chart says. 3 youths of equal stature. You give one of them something so he could stand over the fence. One is down in a ditch and the other is chained. We need to acknowledge the structural problems that limit access to opportunity for some and compensate for that so that they have, in fact, equal access to opportunity. Plato said this: there is nothing so unfair as the equal treatment of unequal people. And we need, as a society and as a nation and as a world, to think about that. It is not enough to open the doors of opportunity. People need to be able to walk through the gates. I have some good news for persons who are providers and are not of the same racial background. Here is a study from Northern California. It found there were racial ethnic differences in the treatment of patients with HIV/AIDS. There were differences in the receipt of the appropriate treatment, in self-efficacy, the patients taking the treatment, and the treatment really working to produce viral suppression. But the researchers had also administered a cultural competence scale. And they reanalyzed the data, and they found when cultural competence was high, regardless of the race of provider, there were no racial inequities. What did it mean to be high on cultural competence? Providers who said family and friends are important to health as doctors, who said social history contributed to how they care for their patients, who said they were familiar with the beliefs their patients had. It means they had to ask them the question, right? That they asked their patients about alternative therapies they use, that they find out what their patients think is the cause of their illness, and they involve patients in decisions about their health care. So you see the kind of in work and communication that is taking place between the provider, and regardless of the race of the provider, when those conditions were there, the study didn't tell us how to get there, but it tells us the goal of where we need to go. What else do we need to do? We need to provide care that addresses the social context. It's not just people just don't need medical care. They need the conditions of life that they face to be different. WHO Commission with Michael Marmot said, why treat illness and send people back to live in the same conditions that made them sick in the first place? I want to give you one example. And what's troubling about this? It's a randomized controlled trial, so it's high quality evidence. This is a 1978 study by Len Syme from University of California, Berkeley. So we've had this knowledge, high quality scientific evidence. It took 244 patients, all of them with hypertension, 80% of them black, randomize them to 3 conditions. Go to your doctor, get your medication, go home. That's one group. Routine care. The second group, in addition to routine care, you go to a class for 12 weeks and a trained public health official teaches you about blood pressure. And the third group, you got routine care, and they got local people, lay people from the community, brought them in 1 month of training of the resources that existed in the community to help people with problems they face, and some basics about blood pressure. And those lay workers made home visits, talked about blood pressure, but as they identified challenges in the lives of individuals, they referred them to resources. They didn't create any new resources, just referred them to resources that existed. What did they find? 7 months later, those who had the lay intervention knew twice as much about blood pressure than the other 2 groups. They were more compliant in taking their blood pressure medication. Blood pressure medication among good compliers was twice as effective in the other 2 groups in controlling blood pressure. And so they were much more likely to have their blood pressure controlled. When we've known this, randomized controlled trials since 1978, and what are we doing with that information? Strategy number 2, we need to identify supportive protective factors and resilience resources. Here is one study done in Georgia. It measured discrimination in black teens at age 16, 17, and 18. And those who were consistently high on discrimination at that young age, by age 20, I didn't say age 40, I said by 20, they had higher levels of stress hormones, epinephrine, norepinephrine, cortisol, higher levels of blood pressure, higher levels of inflammation, higher levels of BMI linked to exposure to discrimination. What the researcher found, though, that among those black teens high on discrimination, but were embedded in good social relationships with their parents, their teachers, their friends, no relationship between exposure to discrimination and biological dysregulation. So social ties was a protective resource. One national study found that for African Americans, 3 aspects of religious engagement, frequency of church attendance, church-based social support, seeking religious guidance in their everyday life, each of these reduced the negative effects of exposure to discrimination on their mental health. So religious resources, if you're a spiritual person, can play a role. Here is a randomized controlled trial among black teens and concerned about the discrimination and its negative effects. And this randomized controlled trial had 3 targets of the intervention. First target was parents. Teach the parents effective parenting skills. How to talk with the kids. When the kids say, I'm feeling this way, don't tell them shut up. Don't talk foolishness. Get over it. Teach the parents how to talk to the kids. And then taught the adolescents self-regulation and taught the kids black pride. And what they found is that when these kids, they had a control group, these kids in the intervention group were exposed to discrimination, no impact on their mental health. Those who had benefited from that intervention, which was not true in the control group. This is a study from Canada. Back in 1987 to 1992, First Nation kids in Canada had one of the highest rates of youth suicide in the world. And researchers went into 196 First Nation communities and found although the group as a whole has high rates of suicide, half the communities had no suicides at all. And so they said, okay, what's different about the communities that have suicides than those that didn't? They identified 5 markers of challenging the federal government of Canada to titles to land, right of self-governance, control over services, the education, the schools, the healthcare, the police and fire, and having a building in the community where they taught the kids their history and their culture. Each of these markers, I'm calling them of protest, advocacy, and empowerment, was associated with a lower risk of suicide. A strong dose-response relationship between having those markers present, getting the kids involved in thinking about the future and in doing things about the future is a mental health protective resource. We need to move further upstream. We need to create communities of opportunity. We need to improve neighborhood environments, provide economic development, housing quality. In the interest of time, I'm only going to talk about 2 of them, but you can go to the paper. We show the evidence that these things work. Investing in early childhood. I visited this program in North Carolina called the Abecedarian Project. Randomized control trial. Take kids at birth, poor kids, 80% black, at birth, and randomize them to an early childhood investment interaction program. This program they are in it from birth through 5. After that, they're not in it. It's just birth through 5 program. What does the program provide? Good nutrition, a nurturing environment, good pediatric care. By age 18, those kids who got the program, remember it's only birth through 5, then you leave them on their own. By age 21, they have fewer symptoms of depression, lower drug use, more active lifestyle, better academic success, better vocational success. By their mid-30s, lower levels of cardiovascular disease risk. Look at the systolic blood pressure differences between the treatment group and the control group. Striking differences linked to investment in children. We also need to improve neighborhood and housing conditions. Here is, again, I'm sharing with you a lot of high-quality studies. This is another randomized control trial that took poor people in public housing in the United States and randomized some of them to move to better housing. That's it. No health intervention. 3 years later, those who moved, all you did was change the neighborhood, improvements in mental health of the children and the parents. 10 to 15 years later, lower levels of obesity, severe obesity, and diabetes risk. Change in the environment is the only thing they did. No health intervention, improve mental health, improve physical health. There's an innovative initiative from a healthcare institution in the United States called the Rush University Medical Center. They found in the area they served in Chicago, there's as much as a 14 to 16-year difference in life expectancy within their service area. And they decided, this is a take-home message, they decided they would change their mission from just focusing on delivering high-quality medical care to improving the health of the community. And they recruited 5 other health systems in Chicago to join them. They created listening sessions to listen to the community. They decided to shift their entire business enterprise to promote community wealth building, which means creating more places in communities where people can apply for jobs, developing apprenticeship programs to help them. They are hiring locally, purchasing, investing in their community, because in many American communities, the healthcare system is the largest sector of the economy. So you can do a lot for economic development. These are some of the things they're doing in terms of improving economic well-being. They plan to reduce the racial gap, these gaps in health by 10%. So I've quickly showed you the problem. I've shown you there are things we can do. What's holding us back? I think there are 3 challenges. We need to raise awareness levels of the challenges. Most people don't know what I've shared with you. So people don't know the magnitude of these gaps that we have. We need to build a science base to guide us in developing the political will, and we need to build empathy. W.E.B. Du Bois was the first black person to get a PhD from Harvard back in the 19th century. He wrote a book called The Philadelphia Negro in 1899, and he had a chapter on Negro health. And as he came near the end of the chapter, talking about the disparities that existed, he penned these words: "The most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race. There have been few other cases," he said, "in the history of civilized peoples where human suffering has been viewed with such peculiar indifference." He's saying the fundamental, the biggest problem is people are suffering and we don't care. We are indifferent. We have no empathy. We don't feel the pain. And research finds that there's a racial gap in empathy on every continent. And that among white children age 5, there's no racial gap in empathy. At age 7, it becomes evident. By age 10, it is pronounced. That's studies in the US. By age 10, it is pronounced. I want to end. I want to tell you about what made it possible for me to be standing before you today. Is the people who have invested in me and the role of affirmative action in my life. With all my hard work and support of family and friends and divine blessings, I would not have successfully launched my career without a minority fellowship from the University of Michigan. And it was one thing to open the doors of opportunity. The other thing is to be supportive of people. You know, in America, they talk about who are people of first-generation college. I'm not first-generation college. I'm first-generation high school. Neither of my parents went to high school. Okay? So I'm an affirmative action baby, and I had Jim House as my mentor, a wonderful sociologist, recently retired, who went out of his way to support minorities and women. We had, when he retired, a celebration back in Ann Arbor, Michigan for him. I was one of the organizers. About 45 of his former students came back. And do you know what was striking? I think of the 45, only about 4 were white males. Wow. It was minorities and women. This does not happen by chance. And we need more people like Jim, who is committed to making a difference. And this was my dissertation committee. Ron Kessler, the most cited scholar in psychiatry, he's a sociologist, was on my committee, and Walter Allen, and 2 scholars from the School of Public Health, Barbara Israel and Victor Hawthorne, was the chair of epidemiology. And even with that, it was not enough. There were 3 African-American scholars with whom I would not be here today. Norman Miles, again, I'm first generation high school. I did not know the difference it made what school you went to in terms of academic success. I was working as a public health educator in Battle Creek, was planning to do a PhD in sociology. The school closest to me was Western Michigan University. If I'd gone to Western Michigan University, I would not be here. And I happened to run into Norman Miles. He's asked me what am I thinking of doing, and I told him what I was thinking of doing. He said, absolutely not. You need to go to the University of Michigan because it's one of the best programs in the country. And I was going to a program. Without that advice, and then Alden Morris. I'm finishing my program at the University of Michigan. I saw the advertisement for an employment position at Yale. I said to myself, Yale wouldn't be interested in me. I did not decide to apply. And I'm walking in the hallway in the sociology department, and I run into Alden Morris, an African-American faculty in the department. And he said, David, I was just got off the phone talking about you. I said, what? We're talking about me? What? He says, oh, I was talking to somebody at Yale. They were asking me who was good coming out of Michigan this year. And I mentioned your name, so you'll be hearing from them. And I said, I don't want to go to a place like Yale. That'd be too much pressure. I want to go to a nice, small school. I can get my work done. He said, David, let's go to lunch. And he took me to lunch and sat me down and explained the way academia works. And yes, you come out of Michigan, it's a top program. There'll be high expectations anywhere you go. But you go to a good place, there'll be resources to meet the expectations. And I applied for the job at Yale and got it. And then James Jackson, mid-career advisor, who helped me, the measures of discrimination I developed, I've written a chapter about it. He was the wind beneath my wings. I shared with him this idea I had of doing this. He said, let's do it. Let's do it. And I'm going to raise money to get a bigger sample and do all of this. And he was there to give me feedback. So it takes a village, and we, all of us, and I'm showing you black and white people made me who I am. So all of us need to work together to create the opportunities for all. I'll leave you with two quotations. Martin Luther King said, "It may well be that we'll have to repent in this generation, not merely for the vitriolic words and the violent actions of the bad people, but for the appalling silence and indifference of the good people." We cannot be silent. We've got to work together. And finally, the words of Robert F. Kennedy back in the 1960s, speaking in South Africa. He said, "Each time a man, and I'll add or woman, stands up for an ideal or acts to improve the lot of others or strikes out against injustice, he or she sends forth a tiny ripple of hope. And those ripples can build a current which can sweep down the mightiest walls of oppression and resistance." It's my hope that each one of us today will recommit to being tiny ripples of hope, so together we can make a difference for disadvantaged people in whatever community we are working, wherever we are, we can make a difference because we are trying to be a tiny ripple of hope. Thank you so very much. You're welcome. I know we're running late, so I don't know if you have time for questions.
Oh, my dear. Quelle parole impressionnante de la part de Dr. William, qui a vraiment su nous encourager, nous motiver et puis bien lancer ce colloque, cette conférence sur la santé mentale des personnes noires. Il ne faut pas oublier vraiment la joie qu'on a de pouvoir cette semaine porter joie et santé mentale dans la même phrase. This is the conference where joy and mental health go hand in hand. So we have a lovely evening before us, but before continuing into this evening, we would like to allow just a brief period for question and answers, and then you will be able to continue the evening with Dr. Williams, with our fellow newly knighted honorary PhD recipients, and with the rest of the individuals in this room. Alors, sans plus tarder, if you have questions, comments, we'll invite you to come forward. There will be mics available for you, and you can pose your questions. And to open the discussion, I will mention Dr. Williams. I'm sorry, I'm against you right now, but I would like to start the conversation and say the important data that you shared with regards to youth and mental health. And I also noticed that we have the blessing here at University of Ottawa to have an intergenerational space. We see individuals of different age, different levels of experience, different stages of their career. And I would like to ask you, based on the quote that you shared, what does it feel like to be a Black child growing up in America, extending that to maybe Canada? How would you suggest that children, acknowledging that they can be very young or even young adults, how can children speak to mental health with their families that may not understand the condition or have the answers to their challenges and experience? Thank you so much, Doctor.
It's a really good question, and it goes back to the point I made about that intervention that reduced suicide. It had two initiatives to intervene with the kids, but one with the parents. And one of the things that young people need is safe spaces where they can talk. And by that I mean safe spaces where we will listen to them. Many parents don't listen to the kids. They tell the kids what they need to do. And before the kids begin, they cut the kids off in terms of expressing what they're feeling. So there's room to create those spaces where the kids can talk. There's a movement as well to limit social media for the kids. I don't think we can eliminate it. I don't think this generation knows of a world without social media, but it's setting parameters and setting limits of its use. But I think the key is really being open to listen and creating opportunities where the kids can share what they feel and are listened to and parents understand. But I think some parents, especially some West Indian parents, need some training in terms of how to listen to their kids and not be completely dictatorial in terms of what the kids, then the kids just shut down. And so you need to create a space where the kids can feel free to share their innermost feelings. I think that's the key that we need.
Thank you so much, Dr. Williams. Certainly, I'm not the only person with questions in the room, but I can go all night. I do have two esteemed volunteers in the room with mics. Il y a des bénévoles dans la salle avec des micros. Alors, if you have a question, please raise your hand with no further ado. I have a question here in the front. Allez-y, go ahead. We have a mic coming to you. Si vous avez des questions, levez vos mains s'il vous plaît et on viendra vous voir tout de suite. If you have a question, raise your hand and we will come to you right away. Merci.
Thanks a lot for a very illuminating talk. You brought the discrimination of race and how it is not eliminated by income or education. And the similar parallel example is there from caste discrimination. And I don't know if you have any experience or publications on that you have done. But my question is, like all the interventions that you demonstrated, most of them, like multi-component intervention, needs to be complex, multi-component, multi-level. And a lot of minutiae of the mainstream research, the purest gods of RCT is like drug A is better than drug B, like clean, simple. And for such kind of atrocities and whatever discrimination going on and the vast effects, we need multi-component, multi-level intervention and how to win that over, because majority of the researcher is indoctrinated that school of purist RCT.
But I showed you multiple examples of randomized trials that were multi-level, multi-component. Think of the one with Len Syme and those local people with 1 month of training making home visits, but he has two other arms that were standard. So, or the housing projects where they randomized people to move and those who didn't move and followed both groups over time. So I think it's possible. I do think it takes a larger vision and commitment to see that the problem is multifactorial and the solution has to address the broader underlying issues and not just the symptoms, but what are the underlying causes. So I think our bigger problem is a lack of vision of what is really needed and how comprehensive it has to be. But there's no reason why we couldn't do more. I'm not saying it's always the case. And then there are people, I'll give you a scholar in my department, Rita Hamad is a faculty member in my department, and she's doing a lot of work assessing the impact, not using randomized controlled trials, but using rigorous econometric models to assess the impact of various policy interventions and documenting which policy interventions have effects on health that apparently on the surface don't have anything to do with health. So I think there's a lot we can do. I don't think our problem is methodology, our problem is vision, that we are just not thinking broadly enough of what's the kind of intervention that we need to do.
We have a question. I'm just over here. If a mic can get there. Thank you so much.
Thank you.
I'm first.
Professor Etoa, go ahead.
Okay, thank you. Josephine Etoa from the University of Ottawa. Thank you, Professor Williams, for such an insightful and inspiring presentation. I've read your work for more than 2 decades, but having you in front of me speak through some of the papers I've read is just an incredible evening. I'm so excited to see you. I think my question is, you've given us so much to work with. Are there some qualitative ways that we can get at some of those structural pieces? Because here in Canada, even listening to you today, I feel like we have so much more work to do. I thought we've done so much, but it looks like we're just scratching the surface.
Do you think you have more work to do than we have with the election coming, with what our possible candidate is saying he's going to do? No, but go ahead. I'm just being facetious.
I think in Canada we have more to do. We're still trying to figure out how to measure many of the things you've measured already. But I didn't hear you talk much about the qualitative aspect in terms of how we can map out some of the structural determinants in terms of the nuances of how race gets into our policy making and a policy implementation and evaluation.
In one talk, you can't say everything. So, but absolutely, qualitative research is very important in terms of us really understanding what the problems are and what the barriers are in terms of effectively working with communities. So absolutely, I think I have been involved. I'm trained as a quantitative researcher, but I've been involved in multiple projects working with qualitative researchers, even now with one with the Cambridge Health Alliance in Massachusetts, trying to understand what are the underlying barriers that these immigrants are facing in terms of accessing health. So yes, I do think that qualitative research can be foundational in helping us to understand in its full complexity the challenge we're dealing with, and then can help us to design how comprehensive and appropriate the intervention needs to be based on what the challenges are. So absolutely, but I don't get into the debate of qualitative versus quantitative. We need both. Both make a contribution, and it's about using both together to move forward. Yes.
Yes, hi, thank you so much for coming and speaking to us. I have a question specifically about children who are followed by Child Protective Care Services. I think it's a very concerning kind of, not even a practice, but just the way we deal with families who have a hard time taking care of their children. I wonder if you can speak to that a little bit about maybe some of the interventions perhaps that have been helpful for children who have been removed. I heard a lot about mentorship, if that's something that's possible for parents, or building communities, building those neighborhoods, those opportunities for those children and families.
I am no expert on Child Protective Services, so I will not say much because I literally don't know. But I in my earlier talk today, I mentioned the U.S. Dream Academy program and the role of mentoring. I am an emeritus member of the board. I sat on the board for 20 years or something. What it does that I think is important, and it's not necessarily, its main target is children of prisoners, because they are at high risk. But in the community, it does not advertise itself as a program for children of prisoners, because then it would stigmatize everybody going showing in the program. Oh, your parents, I didn't know your father was in prison. Oh, that's why you're in this program. So it doesn't advertise that, but it's targeted, but it's also targeted at children in disadvantaged communities who are falling behind in school, because they are on the same trajectory. And what it builds is academic enrichment activities and so on, but what Wintley thinks is the key is increasing the density of supportive others, letting them know we are giving them skills and resources, but we are creating those safe environments where they can talk. We are giving them a positive orientation and fun. That's why it's called the U.S. Dream Academy, because it's taking those kids and letting them dream beyond what they thought their horizons could be. So I do think that approach is useful. I don't think that completely takes the place of all the help that they would need, but it is one step of providing high quality skills plus the social support and mentoring that the kids need. But maybe someone else can tell you more about the Child Protective System, because I don't know all the details about that.
Thank you so much, Dr. William, and thank you so much for everyone who helped open the question period. As you can tell, the conversation is just beginning, so we will continue the question and answer period into our cocktail hour. We can already smell the food, and we can also smell the beginning of a wonderful evening. Alors, merci vraiment à vous tous pour vos questions. Gardez vos questions au bout de vos lèvres parce que vous allez pouvoir continuer la conversation avec Dr. William, avec nos autres invités d'honneur pour poursuivre le reste de la soirée. Alors, sans plus tarder, je vous passe la parole à mon collègue Schwab.
So we'd like to thank Dr. Williams for such a robust and tremendous presentation. Please, let's give it up for Dr. Williams. We were hoping that he would stay with us for the next couple of days, but he has to fly out tomorrow.
But he's here tonight. Look, the glass is half full.
Dr. Senat did that on purpose so that we'll hunger and thirst for more. Yeah. So basically, for the next 2 days, 3 days, 2 days, sorry. The conference is happening at the Faculty of Social Science, 120 University Private. Please don't miss it. We're waiting for everyone. So this is the second national conference, Black Mental Health, Reclaiming the Path to Joy. Ce sera le deuxième colloque, au fait c'est le deuxième colloque national sur la santé mentale des communautés noires, reconquérir les sentiers de la joie. And as the second and third day unfold, we'll hear from some living legends such as Dr. Myrna Lashley, and she is a living legend. Yeah. No. No, you live long. You live long. Yeah. And Dr. Jude-Marie Sena, Dr. Angela Heaney, Dr. Josephine Etoa, who is here, Dr. Peter Feary, Dr. Amar Bisoka, Dr. Eric Jarvis, Dr. Daniel Derivois from France, who's actually back by popular demand. The first time we was here, we just couldn't get enough. So we're happy that you're here, sir. Thank you for coming. And the concurrent sessions will include subjects such as the impact of racism on mental health, l'impact du racisme sur la santé mentale, safe communities, building joy through safe communities, building joy through adversities. Des communautés sécuritaires, construire la joie à travers l'adversité. Black youth, students, mental health et Canadian issue, la santé mentale des jeunes et des étudiants noirs, un problème canadien. We also look forward to seeing you on Friday at the launch of the Black Fit project in the University Square, lancement du projet Black Fit à la place de l'université ce vendredi. Thank you. Molly, it's yours.
So on top of the incredible plenary sessions, concurrent sessions, and other activities planned for this conference, we also hope and expect to see you during the evenings for the additional events that we have specially prepared for you. Alors ne manquez pas, s'il vous plaît, demain soir, le 17 octobre, nous allons avoir une séance intitulée « Entremêler le tissu de l'équité en matière de santé avec les communautés afro-caribéennes et noires ». Intertwining the web of health equity within the Afro-Caribbean Black community. Please be there. On va continuer les discussions qui ont déjà commencé aujourd'hui. We also hope that this will be an opportunity for a number of us to be able to network, exchange ideas on Black mental health, and don't forget, we're always happy and eager to feed you. Ne manquez pas, s'il vous plaît. De plus, on va avoir la cérémonie de fermeture vendredi le 18, là où on va aussi avoir une séance cocktail, a cocktail hour to close our ceremony on the 18th, Friday, October 18th. Alors, ne manquez pas. Please do not miss. I'll take a moment as we get ready to engage in the cocktail hour to remind you of some of the powerful words that Dr. Williams shared today with regards to the mentorship and support that he received to be able to bring him to be where he is today. We are having a discussion today on Black mental health, but this conversation is not just for Black people. We all need to be a part of this discussion, and we can all change the trajectories for individuals in this room and individuals who haven't even heard about this conference yet. So please use this cocktail hour as yours to be able to get you encouraged for the next steps for your own mental health, but also for the mental health of your community, Black, white, and others. Merci d'utiliser ce moment, peu importe votre âge, peu importe votre stade de carrière. Je profite de cette estrade pour vous le dire. I am a product at the University of Ottawa. I've been mentored by Jude. I have the pleasure of working next to Drissa. I see my dean, Dr. Thibault, in the room, and I want to implore for you, whether you are undergraduate student, master's student, PhD student, make this conference yours. You do not know what your future holds. There is a lot of joy in having this discussion on Black mental health. Nous sommes privilégiés d'être ici. Alors profitez bien de votre soirée, de vos soirées à venir. Thank you so much for being here today. Congratulations for you all. Have a wonderful evening.